So next is gastric cancer and helicobacter pylori. It's V6. But before going into the gastric cancer, there's a lot of basic sciences which are very important regarding the stomach. So first of all is the blood supply of the stomach. So stomach has four main vessels. On the lesser curve are the gastric arteries. On the top is the left gastric artery, and towards the pyloric canal is the right gastric artery. On the greater curve we have two gastroepiploic arteries, and on the top is the left gastroepiploic artery, and on the bottom is the right gastroepiploic artery. The other question is gastric lymph node stations, D1 and D2. So all the lymph nodes which are around the perigastric, they are called D1. They start from the right and the left cardiac lymph nodes, right lesser and greater curve lymph nodes, and supra and infrapyloric lymph node. These are six regions which are called D1, and D7 starts with the 7 is called left gastric artery, and 8 is common hepatic artery, 9 is celiac trunk, 10 is 10 11 splenic hilum and splenic artery, and 12 is hepatoduodenal ligament lymph node. These are D2 lymph nodes. The other thing is you should also know between Roux-en-Y anastomosis and Billroth 1 reconstruction, and you should know the difference. So advantages of Roux-en-Y are that absence of bile reflux, good and safe anastomosis with low leak rate, and low risk of obstruction at the gastric bed recurrence, anticolic or retrocolic. And disadvantage is loss of endoscopic access to the duodenal papilla for any biliary pathology, and possible nutritional problem due to the non-physiological food passage. And Roux-en-Y reconstruction, the jejunum should be 30 centimeter distal to the ligament of teeth should be detached, and the distal limb should be brought up to make a joint with the gastric remnant. And then the jejunal anastomosis should be constructed 40 centimeter distal to the gastrojejunal anastomosis, and mesenteric defects are closed to prevent the internal herniation. Okay, so again you should know the difference between Billroth 1. They might ask you to draw the picture. How you will do make anastomosis for Billroth 2, how you will do Roux-en-Y anastomosis, and that's it. Let's come to the scenario. A 70-year-old lady is referred for an OGD to investigate epigastric discomfort and microcytic anemia. You find a malignant appearing 3 centimeter ulcer in the gastric antrum. Biopsies confirm adenocarcinoma and helicobacter pylori. What is the relevance H. pylori? So there is a mechanism of pathogenesis how H. pylori caused the cancers. H. pylori is a bacteria which damage the gastric mucosa by producing enzyme urease and ammonia, and acetaldehyde and toxins which are mucolytics. These attract inflammatory cells that induce chronic pancreatitis. So chronic pancreatitis go towards the atrophic gastritis. Chronic gastritis go to atrophic gastritis. Atrophic gastritis to go to intestinal metaplasia, and then eventually gastric cancer. So H. pylori eradication reduces the inflammatory reaction and halts the development of intestinal metaplasia. So nowadays, because of the widely use of H. pylori eradication regime, now the gastroesophageal cancers are on the rise. So what are the next step in the management of this lady's malignant gastric ulcer? So first of all, I will meet the patient and explain the diagnosis and the findings, and then I will also introduce upper GI specialist nurse to the patient, and we will organize CT, staging CT, thorax, abdomen and pelvis, and then we will discuss an upper GI MDT. Would you consider endoscopic treatment for this lady? Now again, this is a bit tricky question. I might, since the Japanese Gastric Cancer Association has recommended that EMR can be possible standard treatment for differentiated adenocarcinoma without ulceration, clinically diagnosed as T1A with a diameter of less than 2 centimeter. And the mucosal, they are also currently endorsing ESD for differentiated T1A with ulceration less than 3 centimeter. Mucosal disease is associated with only 3% incidence of lymph node mets, and this rises to 20% for cancer extending the submucosa. Once the disease involves submucosa, chances of spread through the lymphatics is on rise. This lady is fit for radical surgery. How would you proceed? Because this is at the antrum, so she requires diagnostic laparoscopy first to assess for small volume peritoneal disease and to assess the local spread of the tumor to ensure operability. Number one, Number two, in the UK, perioperative chemotherapy is the standard of care for patients with localized gastric or type 2 or type 3 junctional cancer. Not mention of type 1. Type 2, type 3 junctional cancer and localized gastric cancer will have chemotherapy of gastric protocol. So the MAGIC trial randomized 503 patients with gastroesophageal junction and lower esophageal adenocarcinoma to perioperative ECF regime administered at 3 cycles before surgery and 3 cycles after surgery or to the surgery alone. In the group undergoing chemotherapy, there was evidence of tumor downstaging without an increase in the intraoperative post-operative complications. Furthermore, this group had 5-year survival increased from 23 to 36%. What type of operation would be appropriate for this lady? So as this tumor is distally, so she will having a subtotal gastrectomy with modified due to lymphadenectomy and preserving the pancreas and the spleen, and with the aim to remove at least 15 lymph nodes. And the procedure after resection, to establish the continuity, I would perform Roux-en-Y reconstruction. As I mentioned in the initial beginning of this video, limited gastric resection should only be used for palliation or very elderly. The distal pancreas and spleen should only be removed if there is a direct invasion of these organs and still a chance of curative or zero resection. What are the common complications, short and long term, which you would discuss with the patient when consenting for the gastric surgery? So immediate complications are anastomotic leak, bleeding, and duodenal stump leak. And long-term complication is again recurrence, dumping syndrome, vitamin deficiencies. She will need lifelong IV vitamin B12, and she will need iron, vitamin D, calcium as supplement to reduce because due to reduced absorption. Now, last question. You are asked to see a 78-year-old lady on medical ward admitted with vomiting and dehydration. A plain abdominal radiograph shows a grossly distended stomach. You suspect she may have a gastric obstruction. Discuss how you would manage her. So I will take a focus history, then I will do examination, and then we will start cessation and correcting electrolyte abnormality, that is usually hypokalemic metabolic alkalosis. And I will take a history looking for symptoms suggestive of malignancy or chronic peptic ulceration. Examining looks for signs of dehydration, any abdominal distension, ascites, mass, or succession splash. Place a large bore nasogastric tube. Lavage may be needed. On once resuscitated, arrange a CT scan with oral contrast to look for mechanical obstruction. Could be interluminal, extraluminal, could be benign or malignant. An OGD may be necessary to obtain the biopsies to confirm malignancy, but only if stomach has been adequately emptied and lavaged by an NG. Therapeutic measures depend upon the cause of the obstruction. Localized malignant disease should be managed as per MDT discussion. Options for palliation include the endoscopic stents. Options for palliations include endoscopic stents, gastrojejunostomy, and palliative distal gastrectomy. For benign causes, the option include balloon dilatation, gastrojejunostomy, and stents. Balloon dilatation, stents, and gastrojejunostomy. Thank you.